This is a 44-year-old female with right breast lump, palpitations, and premature ventricular contractions. Mammography showed a subtle difference of breast density at the site of the palpated lump at the 9 o'clock position of the right breast, which is seen here denser than the 3 o'clock position of the left breast. Ultrasonography showed a well-defined lesion at the same location, and elastography showed it to be rather hard. MRI showed a well-defined enhancing lesion with increasing level of enhancement over time, a feature of fibroadenoma. This is an interesting technique to see the time intensity curve, not to see it as a curve, but to see it on the image itself. Subtraction of the delayed minus the early gadolinium enhanced images shows carcinoma usually as a very dark structure due to washout. The opposite is true for benign lesions. So this is here bright means that the enhancement is increasing over time and means that the lesion is most probably a fibroadenoma. For one reason or another, it was decided to biopsy the lesion and the result was a fibroadenoma. But this is not the main point of this case presentation. The point is that there is, at a slightly higher level, a lesion in the left lung, which is enhancing. This lesion was not reported at that time, and because the patient had also palpitations and premature ventricular contractions, MRI of the heart has been performed. On the initial transverse images taken for localization, this same left lung lesion has been seen. It has been a little larger than on the breast MRI, and it has been reported this time on the cardiac MRI. Therefore, CT of the chest has been performed. The lesion was found to have the typical speculated border suggestive of bronchogenic carcinoma. Has been biopsied and showed that the lesion is a pulmonary adenocarcinoma acinar subtype. PET-CT was done for staging, and the lesion was the only malignant neoplastic site. That's the advantage of the incidentally seen bronchogenic carcinoma, that it is seen at an earlier stage. The lesion has been successfully resected. This is the chest X-ray after left upper lobectomy. A previous chest X-ray was reviewed to see why the lesion was missed. This could be a quiz to the audience. Where is the lesion? Those of the audience who want to test themselves can pause the video and try to find it. This extra density here is the lesion. It was missed because of its superimposition on the left parahilar region. It would have, of course, been easier to pick it up had it been more laterally located and surrounded by lucences on all sides. Difficult to diagnose, of course, particularly in a chest X-ray done for cardiac symptoms. Yet it is a reminder to us that the concavity of the hilar shadows needs to be respected. This is the concave outline of the right hilum. Looking at the concave outline of the left hilum, you see a density outside it. That's the lesion. Actually, the lesion is not parahilar. The lesion is anteriorly located, but it is superimposed on the parahilar region. This is a three-dimensional reconstruction of the lung surface. We'll see now the signature of the bronchogenic carcinoma on the lung surface. There is linear branching retraction of the lung surface at the site of the lesion, though the main bulk of the lesion itself does not touch the lung surface, as we have seen on the sections of CT, but the spiculated margins, some of the spicules are reaching to the lung surface and exerting traction on that surface. Here on this tangential view, you can see that the lesion itself is not reaching the surface, but some of the spicules coming out of the lesions are. So diagnosis here is pulmonary adenocarcinoma, acinar subtype, and a breast fibroadenoma. We have seen on the breast MRI how the attention was given to the benign lesion and ignored the malignant neoplasm. No blame, of course, but encouragement of everyone to look outside the concept of the exam requested. The learning points are: bronchogenic carcinoma may be clinically silent and incidentally discovered, a situation which has a better prognosis, of course. Bronchogenic carcinoma may be missed on chest X-ray done for another purpose or on pre-employment chest X-ray. It may even be missed on chest X-ray done for lung lesion screening if the lesion is at a hidden or a partially hidden location in the lung. We learned how to give attention to the normal concavity of the hilar shadows. This helps detect hilar lesions, parahilar lesions, and lesions like this one, which are anterior or posterior to the hilum but are superimposed on the hilar shadow. We learned to look outside the box. This may help diagnose serious malignancies, and the present case is an example of that. It has been detected as an incidental finding on the cardiac MRI. It could have been detected on the breast MRI even at an earlier stage. And other examples of situations where bronchogenic carcinoma may be incidentally detected, all of us who have some years of experience with imaging have once or twice or more seen a bronchogenic carcinoma on, for example, a shoulder X-ray as a pancreas tumor, on barium swallow, on MR angiography of the aortic arch, again as an apical lesion, on breast MRI or on cardiac CT or MRI as in this case. This is not only for bronchogenic carcinoma, but colon carcinoma is known to be seen many times on unenhanced CT done for stones of the urinary tract. There has been a widespread use now of CT for assessment of stones of the urinary tract instead of the old use of plain film for the same purpose. And on this unenhanced CT of the urinary tract, it is frequently you may discover for the first time a colon carcinoma, or alternatively miss a colon carcinoma which is later diagnosed, and then on retrospective review of the earlier unenhanced CT you find that it was there. MRI of the spine has also the chance to discover for the first time a renal cell carcinoma on the coronal scout, or a rectal neoplasm or a gynecological neoplasm on the sagittal sections in front of the sacrum. We learned that bronchogenic carcinoma has its own signature. These are linear branching and radiating retraction of the lung surface. This happens even if the bronchogenic carcinoma, if the main bulk of the bronchogenic carcinoma does not reach the lung surface, but because of the retraction exerted by the spicules coming out of the surface of the lesion. This does not happen in metastasis and in a couple of other lesions, and may help differentiate the lung lesion if you do the lung surface reconstruction and have a look at the signature of the lesion.